Welcome to the Virginia Mason Institute webinar, Capturing Value in Patient Voices and Perspectives. My name is Susanna Garitano, and as an Institute team member, I am proud to introduce our presenter today. Ellen is a transformation sensei at Virginia Mason Institute. She's a trained clinical nurse specialist, and she was the Director of Quality and Safety at Virginia Mason Medical Center prior to joining the Institute. As an Institute leader, she led system-level improvement work in medication safety, nursing and care team workflow efficiencies, pain management, and patient safety. Ellen is a Kaizen Fellow graduate certified in the Virginia Mason production system. Her knowledge of clinical processes, team development, healthcare outcomes, and regulatory performance provides a solid foundation for an extraordinary learning experience, and I suspect that you'll benefit from her depth of knowledge and skill today. Ellen will address a number of pre-submitted questions during our question and answer session following the presentation today. Today's session is also being recorded and will be posted on our website. In addition, each of you will receive a link to the recording and the Q&A document via email following this session. Thank you for attending, and I will now hand it over to Ellen.
Thank you so much, Susanna, for the nice introduction, and welcome everyone to the webinar today. Engaging patient and families is imperative in the work that we do, so our objectives for this wonderful webinar this morning will be to learn how to create opportunities and roles for patients and families to really partner in organizational improvement work. Again, to see how we can begin to implement improvement using real-life feedback from our most precious resource, our patient-family partners. And finally, to understand how incorporating the patient perspective stimulates and energizes our creative thinking and breakthrough innovation for healthcare organizations. Imagine for a moment what healthcare would look like if every decision we made included the central source of truth, namely the voices, observations, and contributions of those receiving care, our patients and families. What could we actually achieve if we demonstrated this belief? At any given moment, would we understand the level of urgency our patients are feeling and then meet them where they are at with the right response to their concerns? Would we listen intently, knowing that their collective perspectives are necessary to shape and influence our next encounters? And finally, would we approach every comment with the ever-important gratitude, fostering a culture where patients speak up and participate at all levels, without reservation, to help us learn and improve? In my life as an advanced practice nurse, I've routinely been responsible for assisting in quality and safety improvements for Virginia Mason Health System. So years ago, many of the decisions we made were served up with some very sound intention, evidence-based practice, with the highest degree of team collaboration and expertise. There were even a certain amount of outcome sustainability that we saw over time. And during those moments, it was really quite easy for us to feel successful as we improved. Yet, what I often recall with surprise and significance were times when the patient or family were not invited in to help us understand their experience. We truly missed the opportunity to avoid our assumptions and consequently exceed our patient expectations. Our process redesign was really only a shadow of what we could have achieved, and consequently low patient satisfaction and marginal staff engagement scores were just a few of the many symptoms arising from a lack of patient-focused inquiry. So during the next hour, I have the privilege of sharing the work of many contributors, from executives to the front line and back, and the alignment journey over time as stakeholders delivered on their patient-centered promise. So please be aware that today we will work from the important premise that our patients' healthcare experiences really define our true reality. Let's please start the conversation with a true story from our early years that highlights our strategic plan and the belief attitudes, namely attracting the best people, relentlessly pursuing quality within the eyes of our patients, creating an extraordinary experience, and fostering a culture of learning and innovation. This is about activating the patient and family voice during actual delivery of care. to help guide exceptional healthcare teams to attain remarkable improvements. So the story goes like this. Jan, we will call her, is a mother of a 21-year-old who was admitted to our hospital due to a stroke. Recovery path for her daughter included an initial stay in the inpatient neurology unit and later in our department of rehabilitation. Care transitions between those units were tenuous at best, as handoffs to the new care teams included broken information flows and some delays in care. Remember, this is a situation like others across the world, and many of you have experienced this, where brilliant and highly skilled workers are being asked to deliver extraordinary care in systems that are chaotic and variable. We were extremely grateful that Jan spoke up during a daily service round. She was very concerned that delays in therapies, nutrition, and pain management would significantly impact her daughter's recovery. We demonstrated our gratitude by acting immediately on our promise of patient first, and within 24 hours convened the care team to come together to study the broken transition process. What made this unique was that Jan was present to tell her story as a team member as we mapped out the process flow together. The managing hospitalist at one point stated that we had truly let her daughter and the entire family down. Having the patient share their story within this process improvement activity created an immediate sense of urgency, which was palpable. And from there, we were able to accelerate and improve. Without Jan's presence, our improvements would have been potentially void of feeling, incomplete at best, and we would run the risk of creating another defective process. So this leads us to discussion around the vision for patient and family engagement, to foster active partnerships for our patients, families, and staff that allow for thoughtful activation of these important team members to inform service redesign. And more importantly, to become an organization with structures in place to routinely listen and deeply understand patient experience. So what I'd like to do now is to walk you through our journey of patient-centric care at Virginia Mason, from our early days to our present state today. And my hope and desire is that this conversation together will trigger for you all new ways of thinking and feeling about patient engagement at your work sites. So our work began in early 2000. As we look at our patient partnership journey, we had to understand what our aspirations were and how we would integrate them into the structure of our healthcare system. How would we know that the vision was alive and well? Well, we had to understand that we were moving from a patient paradigm that identified patients as our strength and our truth, that there was importance in discovering and investing in our patients so we could discover together to improve the quality of life for the family, the patient, and the community, to be an organization that was truly committed to imparting our patients as team members, to work with us in improving processes, and to ensure that we were inclusionary and open, without reservation, understanding that our patients and their families were equal partners. These attributes were our barometers as we began to discuss patient and family engagement. This is a terrific slide because, again, it anchors our journey in the early days to our current state. This is a Redesign Continuum for engaging patients and families in process improvement. We first had to understand where we were and where we wanted to be in those early days. So this patient engagement continuum begins with best intention, and it focuses on including our patients in their care and process design. And as you can see, we began on the far left with listening a little to our patients, then designing our processes, and designing and then asking for patient input. You can start here as well. And I'd like to give you some examples of how we aligned our expectations to our beginning journey. The purpose of this slide here in 2001 is to show how we structurally created alignment around patient-family engagement. As you can see, our compacts shown on the slide have clearly embedded our early desires to engage patients and families in the process. Our physician compact, which I'll talk about a little more in just a moment, embedded into their physician responsibilities this importance of encouraging patient involvement in care and treatment decisions. And equally, our leader compact promoted a culture where the patient comes first in everything we do. This is about solidifying our strategic vision of our patient-family partnership. So again, the challenge to achieving our vision, as with so many things in healthcare, involves our ability to align expectations and accountabilities across the organization. And these were two key areas that we focused on. So let's talk a little bit about the Physician Compact in 2001. This allowed us to outline clearly what our physicians expected from the organization on the left-hand side and what we expected of our physicians on the right. So a symbiotic relationship where two parties have equal contributions to the whole. So this process required a year to thoroughly engage all physicians to define what was needed in discussions, strong executive and physician leadership, and it continues to live today as we hire our new physician cohorts, as we look at our onboarding and performance reviews, and even is brought up during all of the professional staff meetings. Alignment is imperative, and we needed to ensure that we were transparent and explicit about our collective behaviors to support our vision of patient as part of the team. This slide looks at the areas that we will cover today during the webinar. This is about continuous process improvement. And I may just put in a caveat here that our lean methodology is what we know here at Virginia Mason Health Systems. So our process improvement methodology that we use is lean process improvement. With that, it allows us to accelerate our improvement efforts and ensure that we are mistake-proofing the process. So we'll talk a little bit about these 5 domains. I'd like to start with the far left, committee and guiding team membership. So we began to engage our patients and family in improvements with committee memberships early on. This is where some of the stories began to emerge as we shared our stories with our committee guiding teams, and our patients and family partners were part of those teams. This is also where our patient and family partners were included in board conversation, whether it be a story that was shared either positively or an opportunity for improvement, as well as having our patient and family partners at board meetings to discuss and describe their experiences. We also worked in a very discreet way around rapid process improvement workshops, and our early workshops did not include our patients. And so we began to understand, as we began to solidify our strategic plan, that we really needed to elevate our participation. So having our patient and family partners on the workshops for the full 5 days, or there could even be a panel and other opportunities to share stories about experiences. They were really very key in organizing some of the important contributions that interface directly with our patients as they received care. The last 3 domains are the family activated safety team, experience-based design, and the peer partners program. And these are the 3 areas that we're really going to dive into over the next short bit of time together. So it wasn't until 2008 that we took our next step forward to a full patient activation promise, and we began with the family activated safety team, which we're going to discuss. And we're going to explore, like I mentioned, the 2 other important areas, experience-based design and our peer partner program. All of these you can begin to develop at your organizations. So this slide shows in 2008 that we had a strategic quality plan 5-year that also, again, was moving our dot towards a more integrated system of patient and family engagement. You can see that we had articulated that we wanted to establish a process for active participation of patient and family members in policy and program development to enhance the clinical care and improve outcomes. And how we would do that was to design and implement an internal patient safety communication process and some education curriculum for our staff, patients, and families. Our family activated safety team was a key element of that. So here we're moving along our continuum, and we're moving towards listening to patients and then going off and designing. So we haven't reached the ultimate right side where we actually have our patients integrated, but we're including them in a more purposeful way in our design, which was very value added as we went along our learning journey. Family Activated Safety Team. The Family Activated Safety Team is a tertiary level of rapid response. So, as many of you know, you have your code response teams, and you also have a medical emergency response structure. And here at Virginia Mason Health Systems, both were actively and reliably in place at Virginia Mason. However, we knew that there was something missing. We had patients and family members who would recognize that there was a concern, and well-intentioned individuals that were caring for them may not have a structure in place to ensure that we address their concerns. This is a brochure that our patients and family receive on admission, and as you can see, it is patient-centric in that we're defining that we believe in teamwork and you are an essential part of the team. The Family Activated Safety Team provides you with extra help when you have concerns. It's easy. You just dial 6FAST from any hospital phone and you will receive a quick response. Within a few minutes, a team will arrive to your bedside to address your needs. Please notice on the right-hand side that there are two very general criteria to instruct patients and families about the patient family activated safety team and the purpose of their team member participation. We want our patients and families to call if they notice any medical change that they're concerned about. And if we're not addressing their concerns, or if there's a breakdown in communication, we want them to stop the line and pull the cord. We had a lot of reservation. We were concerned that our patients and families might use this in an inappropriate way. Well, what we found was that our patient and families used it for just the right reasons. You can see that from these 97 family activated safety team calls, our patients and families knew exactly why they needed to call, and they were the right concerns. Pain medication and medication delivery topped the list. Delays in care, defects around plan of care or communication, or a lack of understanding around a patient and family's plan of care was another reason that our patients and families called F.A.S.T. Dissatisfaction with staff, there was some psych issues, diet, and environment. Many of these calls were multifactorial, and we, on average, had somewhere between 3 and 5 calls per month. We deployed a team which included a critical care nurse to screen for physiological safety, and most importantly, patient relations was in charge of this work and ensuring that there was closed-loop communication so patients and families received the care that they expected. So within 24 hours of the call, our patient experience specialists would arrive to ensure that patients and families had their needs met, that they understood their care, and that they felt comfortable with the care that they were receiving. The Family Activated Safety Team allowed us to trust our patients and to prove to them that they were truly a key quality and safety member in their delivery of care. We applied the countermeasure of mistake proofing to our Family Activated Safety Team design. Remember, our strategic plan puts our patient first and ensures that we are providing 0 defects. As we designed the Family Activated Safety Team, we used some key strategies to ensure that we were creating a reliable and a resilient process. It started with multiple simulations, some scripting, and from that came standard work and an algorithm that was designed on the functionality of roles and responses, the ability to create a structure that allowed patients to inspect at the source and allowed us to respond quickly to their concerns. This innovative idea that our patients could actually stop the line if they felt something was wrong, and for us to trust without hesitancy that their voice was imperative. And finally, to use the plan, do, study, act cycle to continue to modify and improve our family-activated safety team. As someone who was integral to this work, I would highly recommend that your organizations consider a patient-activated safety system that allows them to speak up in real time. And if you have any questions, we're happy to help you with that. Let's move on to our Patient Family Partner Program, and one of the really exciting, innovative strategies that we used for experience-based design, which is this ability to ensure that we are not only understanding the process flows within our system, but also capturing the emotional feelings surrounding specific touch points in our healthcare design. This is very cool, and I think you'll enjoy it, and we'll provide you with some reading sources if you'd like to explore this further. So, experience-based design, what in the heck is this? Well, it's a philosophy and a set of methods focused on understanding the experiences and emotions of those who are involved in receiving and delivering healthcare services. So, not only our patients, but also our staff who are delivering those services to the individuals that we care for. Our goal is to really strive to understand how people naturally feel and think and what they're doing in the process. So what really matters to our customers. So let's look at the next step. And understanding that our technical lean tools, which is our value stream mapping and some of our methodology, provided us with a really clear understanding of process steps. But we also knew that we needed to incorporate the emotional experience of our customers to really understand the experience. So some of the questions that we asked were, how do negative and positive experiences impact our quality and our safety? What does the process flow look like? But most importantly, within that process flow, what are the stories and emotions and feelings that are generative to process improvement? So let's take a moment to explore this slide as we look at some process steps and potential touch points. As you can see, this process takes a patient through a very short cycle or lead time from admitting in the clinical setting to room sequencing to maybe some pain assessment and meeting with the surgeon during a primary care visit. A very short cycle of experience. But please notice that the process is built from the patient perspective. In admitting, it's I'm meeting a new nurse. In room sequencing, one of the steps might be I'm wait in the hall. During the pain assessment, the patient may feel that they are in pain. And meeting with the surgeon, if it's a tenuous conversation, there might be some feelings and emotions around receiving bad news. So within the value stream or the process flow, the focus really turned to understanding the patient's emotional state and response. And from this harvesting, we could then quantify the emotions and improve the system. So I hope you can all see that within each of these steps, admitting seems like sort of a benign process cycle of work. Yet if they're meeting somebody new, there might be some anxiety or there might be some enjoyment around that. So capturing the emotional context was a really important part of understanding the patient experience. So experience-based design is based on a methodology and a bundle. And for any of you who've done qualitative or been exposed to qualitative research, there are a lot of similar elements. It's sort of a qualitative research light within the science of observation. So these are the 4 strategies for experience-based design methods. Of course, you're going to do observations using a big eyes and big ears and a small mouth, really spending time watching and looking at the experience that the patient is receiving and following them through their entire experience, a key element and good place to start. You may also be involved in interviews and collecting stories using open-ended questions and some key strategies to elicit emotion and help patients expand their story as they go through the interview process. Questionnaire is also another strategy where there is a defined emotional pick list of words that the patient's allowed to pick from as they're walked through each of the process steps that they experience, so each touch point. And then finally, the possibility to do focus groups if you'd like, to guide them through a common experience. So all of these make up the experience-based design bundle. Let's talk a little bit more about what a touch point is, because I've used that word a couple times. So this is about the moments in which patient or family members experience an emotional response during healthcare delivery. It's subjective, it's memorable, and we also often find that we are surprised by what their emotional response is. So it may not match our idea of our process steps, but it can be understood through observation and emotion words. So this emotion word set has been used pretty frequently here at Virginia Mason. It's used within our workshops as we're looking at some of our quality metrics for our rapid process improvement workshops to understand the emotional construct and the emotional touch points that patients are experiencing through the process. Because again, their voice is the true reality of our quality and safety within the work that we do. But basically, it allows us to achieve an avoidance of assumptions because we collect data based on a discrete set of emotional words with consistent meaning, and we can then validate those emotional word sets, capturing, importantly, positive, negative, and neutral emotions. So our categories that we utilize are positive, negative, and neutral. And what this allows us to do is to quantify very, very quickly the percentage of positive, negative, or neutral responses at a specific touch point in the value stream. So again, this is one of the standardized questionnaire strategies, one of the 4 strategies for experience-based design. And we've used it very, very actively here at Virginia Mason. Okay, let's move along to our patient-family partner program. Our next step as we matured in patient and family integration has landed here for the moment with our patient-family partner program. So many of our staff are trained in lean methodology, namely the Virginia Mason production system. And through that process improvement method, we were able to develop the knowledge, structure, and tools necessary to design and sustain a patient-family partner program. Really allowed our organization to implement a sustainable program using our lean methods, which empowered our healthcare organization to embrace the voice of patients and family members by incorporating them as partners in improvement work. So let's revisit our Redesign Continuum as we move over to the right side, the ability for us to listen to patients and then go off with them to design. Creating patient-family partners requires us to look at the process steps necessary so that our patient and family partners feel prepared to contribute. This process flow map outlines the steps from recruitment to engagement. And our process flow allows us to create ready patient-family partners. The 6 cycles of work are recruitment, identify interests, an interview process along with an orientation, a structure in place to ensure that we have access to our patient and family partners based on requests, and then finally, placement. When we first started this work, we used our Press Ganey surveys, and we included a question in that satisfaction survey that allowed patients to self-identify if they were interested in the process. That was a great place to start. This process not only sets up our patients to be able to successfully contribute, it also sets up our organization to be able to harvest the important feedback from our patients and their families. As a reminder, each cycle was influenced by our lean methodology as we developed standard work and ensured that the design included patient and family inputs in each of the cycles of work to ensure that their perspective and their voice contributed to the process. This snapshot is an example of some of the metrics we tracked for quality standard evaluation of the program. It shows some of the topic areas that our programs support and some easy metrics to gather as patients volunteer and are chosen for active duty. So we had 260 total encounters in a 2-year period. This is a snapshot. We had patient and family partners involved in content review. They did some individual speaking. They were included in panelists, also in our workshop panelists and workshop involvement, and then our lean improvement workshops. So a fairly robust amount of encounters, which again is a great metric if your organization is looking at the value add for having our patients and families involved in the conversation. Here are a few examples of the patient co-designed products. I'd like to run through the list quickly with you all because I think there's some interesting topics here. We started early on with some of the Know Me, Understand Me forms, which were forms that allowed our patients and families to express who they really were outside of their health diagnosis. So we utilize this heavily in our critical care unit and diabetes management. Those are some of the very first Know Me pamphlets that allowed our staff to really understand who the whole person was that they were caring for. Our patient and family partners helped us create some delirium alert cards because, as we know, our patients and families know what's normal and what's abnormal most discreetly and are really able to help us understand when there is an abnormal situation with the people that we're caring for. They were also involved in the peer partner rounding program development for our total joint replacement patients, as well as our laryngectomy patients. And they were integral in designing those preparatory classes for those individuals receiving that type of care. They informed our informed consent process. They helped us understand persistent pain and the important conversations that needed to take place during the pain rounding huddles. They helped us with provider training as providers delivered bad news to patients and families, and using the experience-based design Touchpoints was a key influencer in this work. They helped us with exercise visuals with some of our rehabilitative medicine, and were key contributors to the sepsis education conversation and pamphlet. Understanding the severity of illness and how sometimes when we provide patients and families with written information when they're not able to assimilate, that really the conversation is the most important thing to have at the moment, and then a pamphlet may support additional learning later. So they contributed in multiple ways, and these are just a handful of the many important contributions that our patient and family partners have made. So a subcategory of the Patient Family Partner Program is the Peer Partner Program. This is really a satellite program to our Patient Family Partner engagement. So the Peer Partner Program was created to provide Virginia Mason patients with a connection to another person who shares similar healthcare experiences. And these volunteers not only provided empathy, companionship, and emotional support, they also encouraged communication between the patient-family caregiver team and primary care. So imagine having volunteers that are well trained, that understand how to converse and share experiences and tips and tricks as somebody was getting a knee replacement or a laryngectomy, or even more importantly, our alcohol withdrawal patients who needed a partner to come in and talk with them a little bit about their experience as they went through alcohol withdrawal. So this peer partner program provides empathy, support, some connection to another individual who has had a similar experience, and our patients and families have appreciated it immensely. Our patient-family engagement would not be complete without a robust structure to share patient experiences and stories throughout the year. So remember our early vision to become an organization with structures in place to routinely listen and deeply understand our patient experiences. Patient Experience Day does this. It's a very, very special component of our Patient Family Partner Program, and it is one of the most significant Virginia Mason cultural experiences to all that attend, because our patient stories change how we see and feel and think about our patients as true partners in healthcare. As an organization, we share freely what we learned during this Patient Experience Day. This is an opportunity for us to honor our patient family partners, and our patient family engagement volunteers. And these are some of the themes that have come out of our patient experience sharing as we have learned together. Our patients tell us that sometimes we build false walls, and that patients and families help us see our blind spots. We hear over and over again that our patients and families want to give back to other patients and families, and that they really enjoy being volunteers. And this idea of co-designing within the workflow is needed and needs to be the way that we operate to really achieve full success. Our patients and families also want us to understand this personal experience that they have, and that oftentimes when you're a patient within a healthcare system, it can feel lonely. And there's a tremendous need for advocates, both from the staff and volunteer level. That being good communication experts and listeners is vital. And that finally, that every patient is our responsibility, whether in our personal direct care or not. Other themes that have come out from the Patient Experience Day have been that leaders feel pretty humbled about what our patient family partners tell us in our giving in their time and effort and expertise, and that we need to reduce jargon that is often crops up within our communication with our patients and families, and that we need to welcome our partners into the work of improving high-risk processes. Sometimes we have trepidation and concern that if we share the highest risk situations with our patients, that might reflect poorly on us. But in actuality, encouraging them to be part of those high-risk improvement efforts is some of the most important work that we do in quality and safety. So here are our Patient Family Partner Program components for success. Our Patient Family Partner Program allows us to recognize opportunities and create roles for our patients and families. It ensures that we have a network of engagement, and it's a reciprocal relationship built on staff and leadership commitment, which allows us to actually sustain the structures that facilitate engagement. And I hope that you have seen today the importance of a structural alignment within our organization, and how our journey has allowed us to start engaging patient and families on a personal level, and has helped move them towards engaging our process improvement efforts at the organizational level. I'd like to share with you a little bit about the Virginia Mason Institute for just a couple minutes to let you know that we're a service organization whose mission is to transform healthcare for the betterment of our communities across the globe. We do offer a wide variety of lean healthcare services and coaching, all rooted in the foundations of lean application and a lean culture in healthcare. And without our lean methodology, I truly believe that we wouldn't be as far as we are today in our patient and family engagement services. We have the longest experiential learning of any organization that applies lean to healthcare, and over 300 years of a cumulative sensei experience to share. As you can see, we work with individuals. We also empower multidisciplinary teams through coaching and mentorship. We help prepare and guide organizations, and our reach is broad and far across the globe. I'd like to thank you for your attention during the webinar today. It has been an honor to spend time with you discussing our journey to capture value in the perspectives and voices of our patients. And if you'd like to get additional information and assistance, we're here to help. Thank you very much.
Ellen, thank you so much. On to the Q&A session.
Thank you, Susanna.
So we did receive some great questions in advance of today's webinar. The first question is, how often do we elicit the patient voice, "I worry about fatigue"?
And what a fabulous question. What we found here at Virginia Mason is that our patients are looking for any opportunities to engage in process improvement. We found that they feel energized when they're included, and also we are energized when we access their improvement suggestions and ideas often and frequently.
Another question, what is the best way to get actionable versus unactionable feedback?
Another really great question from the group. Our actionable feedback is really dependent on the structures that we have in place. And as you heard today, we have multiple structures in place to assure that we're not only hearing our patients, but that we're acting on them. And so when we have structures that allow our patients to provide feedback in a way that is a 360 view of their patient experience, we benefit greatly from that work.
Okay, great. What tips can you provide in engaging senior or older patients for feedback?
Many of our demographic patients are in their senior years. They have a wealth of information and a desire to contribute to the experiences that they have in healthcare. So our ability to listen, our ability to take time to understand their perspective, and understand that their perspective is really the source of truth that allows us to design our processes for our patients is a key element. So patience, having structures in place, and then an actionable agenda post-feedback harvesting that allows us to move forward is key.
How do we integrate patient advocate groups with capturing patient voices?
You know, that's a very interesting question. I know from many of our global transformation clients, they have panels in their international organizations where they have long-term relationships with patient panels that allow them to provide improvement. So this is a structure in place that allows them to consistently provide feedback as they're improving processes in healthcare. So with an advocate group, there may always be a risk of losing objectivity from the panel because of the strong relational ties that panelist or that advocacy group has with the providers in the conversation. So they are a great resource. It's an excellent place to start as you're looking at developing your patient-family partner programs. And you should just be aware and consider that there may be some loss of objectivity in the process.
Good feedback. Next question. What is most critical to preparing a patient to participate in an improvement event, or for us, a rapid process improvement workshop?
Yeah, that's a great question. If you think back a few minutes ago, we talked a lot about our experience-based design and our patient-family partner program. As you saw in the previous slides, it was very important to have a flow of preparation all the way from screening to interviews to orientation. And if patients and family partners know what to expect, understand what their experience is going to be like, they have a much greater opportunity to really produce and provide tremendously important feedback to the improvement work.
Okay, next question. How do we balance patient confidentiality with organizational transparency?
Yeah, that is a really interesting question. I think in healthcare, oftentimes we are hesitant because we feel that being transparent provides either risk to our patients or to our organization. Obviously, in any type of an interaction, we'll be protecting the healthcare information of the patient. And oftentimes they are very willing to share their stories along with their name and the story that's associated with their experience. So ensuring that you have approval from your patient and family partners, we have an opportunity to discuss that with them and to ensure that we're sharing just what they would like shared in the story that they are involved in and the improvement work that they are contributing to.
Okay, great. We do have a few more questions. How can leaders empower frontline staff to create effective partnerships with patients and their families?
Yeah, that's a really great question and one that's very close to my heart. We talked a little bit today about the Family Activated Safety Team, and this allows us to include the patient as an equal team member in their care planning. Oftentimes our frontline staff are the interface between our patients and their families and the care team. And so allowing a structure to unfold as the Family Activated Safety Team does that allows our patients and families to stop the line or raise a concern with an experience that the staff member has alongside of them as an advocate is a fabulous way to include and incorporate frontline staff experience into that patient and family partner engagement.
Next question. How do we engage executive management to understand patient voice?
Wow, that's a great question. Virginia Mason Health System in the past and early on in their journey knew that the patient stories were the things that changed our behaviors and actually influenced our processes. And so very early on, our executive leadership made a clear decision to integrate patient story into many of our management structures. So our monthly manager meetings, daily huddles at local unit sites, as well as integration of the patient and family story into our board reports and our board experiences was really a key element of engaging our executive management in the patient voice initiative.
Okay, I've got one last question. How can we achieve engaging patient voice and feedback in urgent care services settings such as crisis management?
Wow, that's a really, really good one. It reminds me of some of our emergency department care that we provide. I think that you have to be aware of the patient's experience very, very deeply with crisis management, healthcare delivery. So I would say don't avoid soliciting that information from the patient, but the timing will be imperative. If someone is going through a deep crisis, it might not be the time to elicit strong emotional response. There might need to be a little bit of a time rest in between the conversation. So allowing your patients to have the say on if they would like to contribute or not, and then accessing their feedback and their contributions maybe at a later time as a reflective approach could possibly be a good way to approach that.
Thank you, Ellen, and thank you to all of our attendees for your participation today. If you're interested in continuing your learning, we have a variety of ways to support your education. You can learn about our training and services, including workshops, coaching and facilitation, and organizational transformation services on our website, www.virginiamasoninstitute.org. And you may email us directly, info@virginiamasoninstitute.org. We also encourage you to leverage our extensive knowledge base on our website, which includes case studies and articles. We do share this content and more on social media via Twitter, LinkedIn, and Facebook. Thank you, Ellen, and thank you to all of our participants today.